to today's edition of Podcast. Today is June 18th, 2024. I'm Rifat Manan in California. Today, we are very delighted to welcome back Dr. Jeffrey Medeiros, who needs no introduction, and he is now the professor and chair in the Department of Hematopathology at MD Anderson Cancer Center. And today he's going to deliver the 7th lecture in the Hematopathology lecture series. And his today's talk would be a continuation of the last one. So when he talked about large B-cell lymphoma, and today he's going to talk about nodal T-cell lymphoma. And at this moment, I want to take this opportunity to have a big shout out to Dr. Aaron Orbach for helping us in organizing this hematopathology lecture series. Thank you, Dr. Orbach, for helping us. And for our viewers, as always, please feel free to post your questions and comments on Facebook and YouTube chat windows, and we will pass them on to Dr. Medeiros at the end of the lecture. Thank you, Dr. Medeiros, for joining us today. Over to you now.
Thank you, Rifat. So good, I guess, morning or wherever you are to you. I'm going to stop the video now because it's distracting and try to focus on the talk. So today, nodal T-cell lymphomas is the goal. And I thought I'd just begin with sort of an introductory slide showing you that non-Hodgkin lymphomas increase with age. The incidence increases with age, and the T-cell lymphomas overall represent about 12% of all non-Hodgkin lymphomas. Now, as you know, and as I mentioned the last time I did a talk, we have these two competing lymphoma classifications. So I will talk about this in just a minute. So let me come back to it. But let me begin just with the WHO as a sort of beginning point. And as you know, in the WHO, the T-cell and NK cell lymphomas are grouped together, have been since the 3rd edition. And we basically can divide them into 6 major groups: the leukemic or disseminated group, for example, T prolymphocytic leukemia; the extranodal group, for example, breast implant, ALCL; cutaneous group, of course, is mycosis fungoides. There's the EBV positive disorders of childhood, a challenging area I don't have a lot of experience with. There are EBV-driven neoplasms, NKT cell lymphoma nasal. We used to call it nasal type. Now we're not using the nasal type descriptor anymore. And lastly, nodal T-cell lymphomas, which is my topic today. I think we have to remember that the TNK cell lymphoma classification system is much more dependent on clinical data than B-cell lymphomas. And this is in part because we know so much less about T cells, and they can show substantial plasticity, and their whole ontogeny is relatively complex. And we don't have normal structures in the lymph node, like a follicle or a mantle zone, to compare the tumors to, which also kind of inhibited progress with T-cell lymphomas. Now, the T-cell lymphomas I'm going to talk about today, which are the ones in the WHO-5, are the following. This is my little, so this is essentially the outline of the talk. And now I'd like to come back to the comparison of the WHO-5 and the ICC to 2022. And I think as you look at these categories, I think it's fair to say that there is no substantial difference. In fact, I think it's fair to say that the differences are almost entirely trivial terminology. For example, if the WHO says ALK positive ALCL, the ICC says ALCL ALK positive. From this point forward, I mean, I think I'm going to make a statement that's a little controversial. I don't see the justification of using the ICC for nodal T-cell lymphomas when they're virtually the same as the WHO classification system. As the WHO classification system has been established for 25 years, I just don't see why we even need the ICC, at least for nodal T-cell lymphomas. So I'm just going to talk about WHO the rest of the way. Here are the frequency of the T-cell lymphomas from a paper a few years ago. The blue piece of the pie is peripheral T-cell lymphoma. That's a nodal, of course. Angioimmunoblastic is the second most frequent. The ALCLs are there, 9.6 and 6.6. So most of the TNK cell lymphomas are nodal, more than half of them. So let's just begin first with ALK-positive anaplastic large cell lymphoma. And here's an initial paper by Dr. Harold Stein, now retired, I believe, in Berlin, and Dr. David Mason, who died young, unfortunately, of acute respiratory distress syndrome after he had surgery for a pancreatic tumor. And this is the first paper talking about ALCL. Of course, at the time, they're using the CD30 antigen, initially known as Key1, because it was created in Kiel. And this is their very first paper. Leonard, of course, is the last author. And now, since that initial paper, which in retrospect is a little heterogeneous, it's got some syncytial variant Hodgkin in it, I think, and a couple other things. There are now 4 types of ALCL. We're going to talk about the 2, starting first with ALK-positive ALCL. And here's the definition in the WHO book. An ALK-positive ALCL is a CD30-positive tumor, mature phenotype, with aberrant expression of ALK. Remember, ALK is not expressed in normal lymphoid cells or normal cells in general, with the possible exception, well, with the exception of some cells in the brain. So when ALK is overexpressed, it's aberrant and usually oncogenic. And this ALK expression is secondary to rearrangements of the ALK gene. Here's a so-called classic, here's one of the examples of a classic variant, highly pleomorphic or anaplastic cells in the H&E section. And this is a old-fashioned frozen section that I'm using because the black reaction product highlights the CD30 positive cells, mostly in the sinuses of this lymph node. These were cases that in the old days might have been called metastatic carcinoma. Here's a case of the monomorphic variant. Now, monomorphic variant is not recognized in the WHO per se, but there are these cases that look like this, so I recognize it, and they can be easily misconstrued as a diffuse large B-cell lymphoma, or possibly even a plasmacytic neoplasm if you don't do the phenotype. But I show you the ALK here certainly makes things clear. Here are the famous hallmark cells. Now, how you define a hallmark cell is in part in the eyes of the beholder. To me, I'm showing you with the arrow 2 perfect hallmark cells with the horseshoe-shaped nucleus and the paranuclear huff between the 2 arms of the horseshoe. But I would say to you, once you see one perfect hallmark cell, virtually every other neoplastic cell in the field can also be called a hallmark cell if you want to, right? And they have I mean, they may not be as perfect, but essentially they're the tumor cells of ALK-positive ALCL, right? Here's the so-called lymphohistiocytic variant. I don't know if you can see my pointer on my screen, but you see the tumor cells lining up along a blood vessel here. And most of the cells with pale cytoplasm are histiocytes. This one's easy to miss as as something else. You know, sometimes you get a lymphoma, you think it's a lymphoma, but you don't know what kind of lymphoma. Whenever you get that scenario and you're kind of scratching your head, do a CD30. Every once in a while, you're going to look like a hero. Here's a case of the so-called small cell variant of ALK-positive ALCL. When I look at the H&E picture here, I don't think of ALCL, right? There's relatively few larger cells that don't even look all that anaplastic to me, but you do the ALK immunostain, and all the small cells have nuclear staining, and the few large cells have nuclear cytoplasmic staining. You don't want to miss this one. This is about 6 or 7% of all cases of ALCL. If you have a T-cell lymphoma in a young patient, you should do ALK. Of course, you should do party CD30 first, right? But even in this scenario, the CD30 will highlight the larger cells you see in the field, but CD30 will be negative on the small cells or very, very weak. And so if it's a young patient and you're struggling, always do the ALK before you're done. Of course, these tumors are CD30 positive, and every single cell is strongly positive, and it has this sort of target look where you have the membrane plus the paranuclear Golgi zone staining, right? I mean, you can see CD30 in other tumors like mesothelioma, whatever, but this kind of unique, every single cell strong with target is pretty unique to ALCL, with the possible exception maybe of embryonal carcinoma of the testes. These tumors are T-cell tumors usually, but they're often negative for 3 and 5. but they may have 2, 43, 7, 45RO. If you're an old timer like me, you know that marker. Now, there are rare cases where you can't show T cell markers for sure. And so they have a null cell phenotype, but we lump them together because these almost always have clonal T cell receptor gene rearrangements, even though they're negative for most T cell antigens. You've all seen pictures like this. This is NPM is on the top row. As you know, that's a pretty, that's a molecule that's present in most cells. The bottom row is normal ALK, and the middle row is the NPM-ALK fusion, which has the 5' end of NPM1, which contains this oligomerization domain, and the 3' end of ALK, which contains the tyrosine kinase domain, the sort of business part of the molecule, right? And this is a little cartoon I drew just showing how these NPM-ALKs usually don't act by themselves. They have to form dimers or even, quatermers, whatever. And they do that via the NPM or the OD region, if it's another partner. And that combining of the molecules leads to activation of tyrosine kinases, which are, Y stands for tyrosine. And of course, they get activated, they get phosphorylated, right? Here's a little cartoon from a paper by Dr. Ingarami and Polari years ago, but I really like it. It's a pretty cartoon, just sort of showing the complexity of the activation of ALK once the NPM-ALK form dimers. You can see the RAS-MAP ERK pathways involved, the PLC gamma pathways involved, and there are other pathways like mTOR, AKT, and of course a very important one, which is sort of in the middle here in orange, is the JAK-STAT pathway, and we're going to come back to that in a little while. Now, of course, NPM1 was the first one described by, gee, I'm forgetting his name right now. I'm sorry, Steve, what's Steve's last name? I'm blanking. But he was at St. Jude at the time. He's in commercial business now, company now. But he cloned NPM1 way back around 1994, 95, and that's involved in 80% of the cases of ALK-positive ALCL, but there are a number of other partners, as you can see here. The tropomyosin 3 is involved in 1-2% of the cases, maybe more like 5%, I'm not sure. Everything else here, every other partner is 1% or less. But so it makes the point, of course, that the partner is not really important in terms of the ALK activation. The partner is more important in bringing those molecules together. NPM1 ALK can be detected by a number of methods, and you all know this. But, most of these methods have some drawbacks in terms of, for example, RT-PCR is only specific for the partner you assess the assay for. Classical cytogenetics, of course, is excellent, but we often don't have the fresh tissue. FISH is terrific, but you can't know the partner usually because there are so many. So you end up using a break-apart probe. But in this instance, because ALK is not expressed normally in lymphoid cells, its overexpression is very helpful for diagnosis. And here's a picture showing top left the nuclear and cytoplasmic pattern that's typical of the NPM1 ALK fusion, right? And the NPM1 is what allows the molecule to go into the nucleus. But to be just clear, the NPM1 ALK fusion doesn't have the nuclear localization signal. So the NPM ALK has to bind to normal NPM, which is in the cell, and that drags it into the nucleus. So you get the nuclear cytoplasmic pattern. The bottom right shows you what most of the other partners show, which is only cytoplasmic staining. The one on the left is an unusual case of a T2X. X is moesin, which is a membrane protein. So you see membranous staining. So the pattern of the staining you're going to see is in part driven by the partner when you do the ALK stain, huh? All right, so you all know about ALK-positive ALCL. I mean, that's been, not too much has changed since WHO4. How about ALK-negative anaplastic large cell lymphoma? This is a little different. It's changed a bit. So ALK-negative ALCL is a mature T-cell lymphoma with uniform and strong expression of CD30, but no ALK. No ALK rearrangement, no ALK expression. Okay. So when you think about it, that's not the greatest definition, right? It's kind of a little bit vague, and you would expect some heterogeneity looking at that, right? So here's a picture of a case that's not bad for an ALK negative LCL. You can see some cells here that I think look like hallmark cells. The horseshoe-shaped nucleus looks like it's got a bit of a starry sky quality to it. You can see the mitotic figures. CD30 strong and uniform, no ALK whatsoever, right? So you want that CD30 and ALK negative LCL to be strong and uniform. You don't want some variable type staining. That doesn't work. Unless, of course, it's something like small cell variant. Okay, so let's I pulled this cartoon out of this paper a year or so ago, just because I like the cartoon. I'm sure there are other papers that are just as good. But this is just showing you the normal JAK STAT pathway, right? So you need a ligand to bind, and you want to bring those JAKs together. When you bring two or more JAKs together, they become phosphorylated, and phosphorylated JAK is activated. This leads to phosphorylation of STAT, and then STAT migrates from the attachment to the membrane, submembrane area to the nucleus, and this drives many of the important cellular processes. As you know, there are 4 different JAKs, 1, 2, 3, and TYK2, and there are 7 STATs. I don't know why STAT 5A and 5B are not like 6 and 7. I don't know the history of this too well. But this pathway is very important in ALK positive ALCL, and it's important in ALK negative ALCL. Now, here's a paper by Joe Curry, who used to be in our department, but now he's the chair at Nebraska. And years ago, when he was a fellow, he did this little paper looking at JAK STAT activation in ALK positive and ALK negative ALCLs. And you can see that both subgroups have JAK STAT activation, less than the ALK negative group, but still substantial. And he showed in a little survival curve there that the p-STAT3 positive group, right? So STAT3 is, when it's got phosphorylated, it's active, right? And then when it's active, it's also nuclear, right? So that's what you're looking at here. That the p-STAT3 group, the activated group, did worse than the non-activated group. Now, this is going to become very clear to you why this is true in about 10 slides. But I want to just emphasize here the similarities in pathogenesis between ALK positive and ALK negative ALCL. JAK pathway is also interesting because of this paper that came out in the American Journal of Surgical Path a couple of years ago. I think, yeah, there's the reference up top. And this is 6 cases they were showing of CD30 positive ALK negative ALCLs. They're calling them PTCL in this because the morphology looks a lot like Hodgkin lymphoma, but they have this JAK2 rearrangement with various partners. Now, this also raises, this shows that ALK negative LCL is somewhat heterogeneous. And also, I just make the point that I don't believe anymore. I think most people don't believe anymore in so-called T-cell classic Hodgkin lymphoma. I think most of things that we're tempted to call that, and they're rare to begin with, turn out to be something else like this. Now, ALK negative LCL has a number of genetic abnormalities. I've mentioned the JAK-STAT pathway. Instead of, the ALK translocations, you have JAK-STAT mutations. You also have TET2, DNMT3A, sort of clonal hematopoiesis genes. And then you have gene fusions, like ROS1 is thought to be a homolog of ALK, and some people have suggested maybe you should put ROS1 cases into the ALK positive group. And then there are other abnormalities listed here as well. So I'm trying to show you that the genetics of ALK negative LCL is more heterogeneous by far than the genetics of ALK positive ALCL, right? And here's this very important paper coming out of the Mayo Clinic, last author, Dr. Feldman, a good man up there, and showing that, the ALK negative LCL group in their experience can be divided into 3 groups. There's a DUSP22 rearranged group, 30%, which has a very good overall survival, a TP63 rearranged group, 8%, which has a very bad overall survival, and then 60% or so were so-called double negative, neither, right? Or they'll call them triple negative because they don't have ALK either, and they have sort of an intermediate prognosis. Now, I would suggest to you that based on a paper like this, you would think, why are we still calling ALK negative LCL an entity? we're actually mixing together a good thing with the bad thing. And I mentioned to you earlier, you know, that well, let me not get ahead of myself. Let's go to the next slide. Now, here's another paper. This is from the same paper, basically showing the ALK positive rearranged group in the black dotted line, the DUS-P22 group doing just as well, and then TP63 in green doing terrible, and the double negative group or triple negative group, if you prefer, sort of with an intermediate prognosis, right? So to me, the ALK negative ALCL group is not only heterogeneous at a molecular level, it seems to be heterogeneous at a clinical level. Here's a DUS-P22 rearranged case. You know, they look different. When they're in the skin, they have epidermotropism. They're more often CD15 positive, and they look more monomorphic and less anaplastic. And so I think when you look at a case, you can guess it might be one of these, right? Now, this DUS-P2 rearranged group is very interesting because if you look at the top right panel, the DUS-P2 rearranged group has very low JAK-STAT signaling, and I think you can see p-STAT3 is activation. We're looking at nuclear staining and how the ALK positive and other groups have a lot of it, and the DUS-P2 rearranged group has very little JAK-STAT expression or activation, right? And then if you look at the bottom left panel, the DUS-P2 rearranged group has very high expression of 58 in HLA class 2. So the tumor cells are pretty immunogenic theoretically, and the host could respond to that. And lastly, the panel bottom right, the ALK positive and ALK negative groups in general have a lot of PD-L1, but the DUS-P22 rearranged group does not, right? So now, going back to the top right panel and the JAK-STAT activation, now you can see why when Dr. Curry did that paper years ago, the JAK-STAT activation was present in about half the cases as compared to ALK positive ALCL, because most of those ALK JAK-STAT negative cases were DUS-P2 rearranged cases. We just didn't know it at the time, right? Now, can you recognize the DUS-P2 rearranged cases using immunohistochemistry, right? Because not everybody has FISH, or they don't have rapid FISH, but theoretically they could have their antibodies and they could make it. And the answer is you can make a pretty good guess, right? The LEF1 is positive, p-STAT3 is negative, TIA1 is negative, p63 all negative in ALK and the DUS-P2 rearranged ALK negative ALCL cases. Now, you could, p63 is very sensitive but not specific, right? So if it's positive, it doesn't make it a DUS-P2 rearranged or it doesn't make it one of those TP63 cases, right? You know, TIA1 is a cytotoxic marker. It's pretty good, but not 100%. p-STAT3 is not 100%. And LEF1 is pretty good, but not 100%, right? So you can use this panel, and you can make a pretty good guess it might be DUS-P22 rearranged. But, you know, you're going to be wrong once in a while. Now, the only other thing about this DUS-P22 rearranged thing I want to mention is that Dr. Chu in our department a couple of years ago collected a bunch of cases of DUS-P2 rearranged in our department, all shown by FISH. And in our department, these DUS-P2 22 rearranged cases, they do just as bad as the ALK negative ALCL cases, and not like the ALK positive ALCL cases. How do I explain that? I don't know. There were a subset of cutaneous cases in the original Mayo Clinic paper. This particular study had very few cutaneous cases, mostly nodal cases, but I don't know if that's the explanation. So you can make, so I've made an argument that ALK negative LCL is highly heterogeneous. I used to say, why are we putting it in the WHO5 as an entity? It's not an entity, it's at least 2 or 3 entities. But in terms of clinical behavior, I don't know if it's 3 entities or not. We need more work on this, right? Our data suggests they don't do that much differently, but they sure as heck are biologically differently. As I still believe, DUS-P2 rearranged cases should be identified separately in the WHO 6th edition, whenever that comes up. Okay, so let me leave the world of ALCL and start talking about, the nodal TFH group, which are pretty interesting in their own right. So now Well, you can see what's in blue. So we're going to cover these three things in this section. So let's take a moment, if you don't mind, to talk a little bit about history, because I think the history helps us understand where we are now. So the term angioimmunoblastic T-cell lymphoma, the entity, was originally described as angioimmunoblastic T-cell lymphadenopathy with dysproteinemia. So that's why I put the AILD there. And then in the 80s, people started to realize that some of these AILD, and that was done by Dr. Rappaport's team, which included Dr. Glauco Frizera, who was first author. I think that's a Lancet paper. Other people had described this. Dr. Lukes at LA had a different name for it. Dr. Leonard, I think, had a different name for it. And you can find some of this described in the 50s in the German literature, of course. Like the Germans are always first, it seems. But not in English anyway. Now, initially, because it was such a heterogeneous looking thing, people were not sure that it was a lymphoma. They thought, well, could this be some sort of pre-neoplastic state? By the 1980s, people started describing cases that they were calling AILD-like lymphoma, which I say in retrospect are sort of high-grade AITL cases, right? Things that were more monomorphic and more looked like lymphoma. And people started showing that there were cases that had flow aberrancies and cytogenetic abnormalities, and then eventually clonal T-cell receptor gene rearrangements. And so more and more AILD-like lymphoma was being recognized. And then in 1994, when they came out with the real classification, they decided to just rename AILD as AILT. And that's where we were for about 20 years. The WHO3 adopted AITL as the abbreviation in the name. It stayed the same, in WHO4. But in 2007, people recognized that AITL cases probably arose from a normal T-cell follicular helper cell precursors. In WHO4R, we started recognizing peripheral T-cell lymphoma with the TFH immunophenotype. And now in 2023, the WHO5 is going one step further, as is ICC. And they're calling these Nodal T follicular helper cell lymphoma, of which there are three types: the angioimmunoblastic type, a follicular type, and an NOS type. So you see how far we've come in about 50 years. The people who first showed that these tumors were from normal or from TFH cells were Dr. De Laval and Dr. Gallard. Dr. De Laval, as you know, is in Switzerland. Very nice lady. I know her a little bit. I've met Dr. Gallard. I don't know him as well. He's in France, of course. I believe isn't he in the Paris area? I'm not sure. Now, here's a normal germinal center stained for PD-1. And this antibody is highlighting the T follicular helper cells, which, as you can see, this is the dark zone, mostly blue to the left, and the light zone has all the TFH cells, right? That's why you see them all in the light zone. Now, what are these T follicular helper cells doing? And the answer is, boy, they're doing a lot of stuff, right? I mean, this picture, I think the complexity of this picture makes the point that they're interacting with germinal center B cells. Their CD8 regulatory T cells have a role. They interact with dendritic cells, and they're involved in, various pathways being shown in the middle here. And basically, germinal center B cells cannot survive without interacting with TFH cells. TFH cells also seem to be involved in IG class switching and in the somatic hypermutation process that normal B cells normally go through. And TFH cells also play some sort of role in suppressing immunity. So when they're present in large numbers, it's going to cause host immunosuppression, right? So I don't understand all the aspects of this particular slide, but I hope you get the point, how important TFH cells are to normal B cell differentiation. Now, we have antibodies to highlight T follicular helper cells, and there's a number of them. Some of the ones that are most specific are CD10 and BCL6, CXCL13, CD57. They're very specific. Maybe I should have put CXCL13 in the second group. But they're very specific, but they're not terribly sensitive. Maybe, I don't know, 40% of really good TFH lymphomas will stain for CD10. So it's very specific when you get it, but not very sensitive. Now we have other antibodies that are much more sensitive, but much less specific. So most TFH lymphomas are positive for PD-1 and/or ICOS, and to some degree CXCL13. But even though they're more sensitive, they're much less specific. You can see these markers in other kinds of T-cell tumors. Not multiple of them, I should say, right? But you can see them singly in other kinds of tumors, so they're not that specific. Now, there are other markers I know less about. I'm listing them here. HGAL came out of Stanford, and they say that's a great TFH marker. IL-21, I don't know too much about that one. Now, this paper I'm here by R.M. Basha is a very nice paper from the Mayo Clinic, where they're using 5 markers to tell TFH from non-TFH T-cell lymphomas. And these 5 markers include CD10, BCL6, CL13, CXCL13, PD-1, ICOS. And one of the points they make in this paper is that about 1/3 of the cases of PTCL NOS, when you stain them up for these TFH markers, they have 2 or more of these markers and will be reclassified as peripheral T-cell lymphoma with a TFH immunophenotype. So some of the things we know about TFH lymphomas are going to change as we add in these new cases to the overall pile. And what we know about PTCL NOS is going to change a little bit too, because we're going to remove some of these TFH cases, right? All right, so let's get to the point. Nodal T follicular helper cell lymphoma, angioimmunoblastic type, is a neoplasm of mature T cells with TFH phenotype, systemic disease, polymorphous lymphoid infiltrate, usually in nodes, accompanied by prominent high endothelial venules, there's a typo there, and follicular dendritic cells, right? So that's a pretty complex definition. So if you don't mind, I'm an old guy, it's hard to make changes. So I'm just gonna call it AITL. Most patients with AITL have generalized lymphadenopathy, B symptoms, big spleen, big liver, skin rash, ascites to a lesser degree, effusions, and they often have laboratory abnormalities, hypergammaglobulinemia, autoantibodies, etc. This is a systemic disease. People with AITL rarely would present with a single site of disease. They almost always present with widespread stage 3, stage 4 disease and a lot of abnormalities. Dr. Dogan and Isaacson, years ago now, proposed that there were 3 morphologic patterns of AITL. Here was pattern 1, where you have residual benign follicles with secondary germinal centers, and the tumor is surrounding these follicles. That's pattern 1. This is hard to recognize as a tumor without, aberrancy by flow or immuno or clonality. Here's pattern 2, where you still have a little bit of residual follicles, but it's pretty much gone now. And here's pattern 3, where the architecture is totally replaced diffusely. But if you look at the bottom right inset, there's an occasional germinal center that may be very Castleman-like looking, where it's just all depleted of lymphocytes and composed of FTCs mostly, right? One of the old names for this was a burnt-out follicle, or some people say Castleman-like follicle, right? AITL also has these abundant HEV proliferation. I'm trying to show a little picture of it here. So there, as you can see, it's polymorphous in the background, and about 60–70% of them have these clear cells, which I find very helpful to think about AITL when you get them. All right, so, what about the phenotype of T follicular helper cell lymphoma, AILT type? Well, they express pan-T cell antigens, but can show some aberrancy, particularly when they're high-grade and ugly. And they have a lot of tumor cells. They need to be T follicular helper cell positive. Now, this is one little difference between ICC and the WHO-5, right? The WHO-5 says you've got to be 4 positive, or you could be double negative, 4/8, and still be called TFH. The ICC says, no, it has to be CD4. You can't be 4/8 negative, right? Now, CD8 positive is out of bounds. You can't be A positive and be a nodal TFH lymphoma anymore. Now, I have seen a couple of cases in my career that look very good for AITL, and I think I probably called them that, but they were A positive, and now they would be kicked out and sent back to the peripheral T cell lymphoma NOS group, okay? Now they have the TFH markers we've talked about. They have increased dendritic cells. I'll show you a picture. And then they have these scattered large B cells throughout them often, and those B cells may be EBV positive. So here's a picture. There's CD3 on top left. There's CD20 top right. Now look at all this FDC proliferation. This is very typical of a, pattern 3 kind of AITL case. And on the bottom right, here's the EBER showing that the cells are positive. And if you do double labeling, most of the time, those big cells are B. So one of the things I always tell our fellows is that B cell lymphomas usually have T cells in the background, but T cell lymphomas rarely have B cells in the background unless it's one of these nodal TFH lymphomas. They usually have clonal T cell receptor gene rearrangements. Interestingly, they can have IgH rearrangements, right? These are these EBV positive B cells in the background, and they can have cytogenetic abnormalities. And of course, their gene expression profile is a follicular T helper cell. That was the method that Dr. D. Laval and Gallard used to show that AITLs came from follicular T helper cells. Mutations are a big deal, as you all know, with the next generation sequencing, and they've made their way into sort of routine diagnosis of T cell lymphomas, particularly for AITL, right? AITL is famous for having TET2, DNMT3A, and IDH2R172 mutations. And this suggests that epigenetic modification is very much involved in pathogenesis. RhoA is a big deal in about 70% of cases. RhoA does a lot of different things. But in the setting of angioimmunoblastic T cell lymphoma, it looks like it's involved in T cell adhesion and polarization. And then lastly, the T cell receptor pathway is also activated in about half the cases. And there are some of the molecules that are often mutated in AITL. So there are cases that we see in our department where we think it's T cell lymphoma and we think it might be AITL, and the mutation panel supports us or doesn't support us, and we change our mind if it doesn't support us, because this is kind of important when it's done. Now, it's not always done here, of course, but it's done a lot, and we lean on it when we get it. Now, these mutations are also interesting because people have shown there's some sort of correlation between the mutation pattern and the clinical picture. So, for example, this paper from Cleveland Clinic, Dr. Andreyka, showing that RhoA mutations are commonly associated with B-type symptoms, splenomegaly, high blood vessel density, greater number of positive TFH markers. Here's another paper from Taiwan saying, slightly different, but relatively similar things, and suggesting that RhoA mutations correlate with a poorer overall survival, progression-free survival. Here's another interesting paper coming out of Germany by the famous Dr. Letitia and team. Dr. Gallard's involved in this paper too, showing that IDH mutations correlate a lot with the clear cells in AITL. So this is kind of nice, isn't it? To have not only knowledge of mutations in this disease, but morphologic correlates with these mutations, right? That's pretty cool. So I made this little picture myself, although I stole the ideas from other people, of course. So the idea is with nodal TFH lymphomas, we have this multi-step genetic pathogenesis. We have a hematopoietic stem cell, which undergoes clonal mutations of TET2 or DNMT3A. And now we have clonal hematopoiesis, right? And clonal hematopoiesis, as you know, is relatively common, and it increases with, the incidence increases with age. All right, now this clonal hematopoiesis theoretically is going to be there if the tumor undergoes some sort of B cell proliferation. So that's why I have the little B cell LPDs there. Rare patients with AITL have gone on to get myeloid disease, myeloproliferative neoplasm, MDS, and they'll have that mutations too, right? Now, to get to be AITL or a nodal TFH, they need to undergo additional, I sound like President Biden now, additional mutations, RhoA, IDH2, R172, right? And that happens in T cells. And then the last part of it is the T cell receptor activation. and other sort of pathways which make them malignant TFH cells, right? So this is a nice example of how the mutations we now think are involved in the pathogenesis in this multi-step way. Now, Dr. Vega in our department has done a nice little paper for an AITL cases. He hasn't published it yet, but he probably will soon because he's a very efficient man. And he did it with a couple of very good fellows, Roman Segura and Yannis Dimopoulos. And, you know, basically, B cells are common in AITL, and they can be EBV positive or EBV negative. Let's start there. I'm going to say 70% of AITLs have B cells in them. And then maybe 50% of those are EBV positive. Now, these B cell proliferations can look like diffuse large B cell lymphoma. They can look like a small B cell lymphoma. They can look like a plasmacytoma. And these B cells may be monoclonal, either by flow or by molecular. Now, the approach, the teaching, the thinking is that we should approach these B cell proliferations in the context of nodal TFH lymphoma cautiously, because it's this, you know, the immunosuppression that's induced by the nodal TFH proliferation. And, you know, there's no proof as of yet that these many of these B cell proliferations do not make the prognosis any worse, although the prognosis is bad anyway. So now, if they're obvious, so for me, I'm a little cautious about it, right? I mean, I need to see a B cell proliferation morphologically. I need to see it meet morphologic criteria for lymphoma for me to even be tempted to say it's a second tumor or a composite kind of case. If it's just clonality by flow or molecular, I will not, I'll mention that in the report, but it will not suggest a composite B component to the tumor. I've got to see the darn thing look like a lymphoma to even talk about this. And then when they're EBV positive, I think it's appropriate to be a little more cautious when they're EBV negative, because we know the EBV positive ones are likely related to the immune suppression. Right? Okay, so now we covered sort of nodal T follicular cell lymphoma, angioimmunoblastic type. Now we're going to talk about nodal T follicular cell lymphoma NOS, right, which is a PTCL tumor with a TFH phenotype that is CD4 positive and expresses at least 2 TFH markers and does not meet the criteria for angioimmunoblastic type, right? Okay, so this is my little cartoon about what I think nodal PT cell with a TFH immunophenotype is, or nodal TFH NOS. To me, we have unequivocal, on the left, we have unequivocal PTCL NOS. Doesn't look like AITL, no TFH markers. On the right, we have unequivocal AITL with TFH markers. To me, PT cell with a TFH immunophenotype does not look like AITL, or looks a little bit like AITL, but not all the features you want, but has TFH immunophenotype, right? It's sort of a middle place for me. And as you know, the data of nodal TFH, PT cell with a TFH immunophenotype is that they don't do terribly well. They're a lot more like AITL than not, and they have mutation panels a lot more like AITL than not, although they often don't have IDH2. So here's a picture of a case that we think is a nodal TFH lymphoma. This case was a little bit easier because we had clear cells. On the top right panel, you can see a germinal center to the left and the tumors to the right. And then they have pale cytoplasm, not really clear, but pale, right? But usually you see some sort of normal components mixed in these TFH lymphomas at the low power. Here's the high power of the immunostain showing that the PD-1 highlights the tumor between some reactive follicles. And at higher magnification, that area of PD-1 is positive for CD4 and ICOS, supporting the T follicular helper cell immunophenotype. But I think that's partial involvement and kind of challenging. Don't you agree? Here's another kind of nodal TFH lymphoma, pretty unusual, so-called follicular type. These are very rare. I've seen 1 or 2 cases in 20 years. At least I've recognized 1 or 2 cases. Maybe I missed one. On the left, it can look like progressive transformation of germinal centers, so PTGC-like. On the right, it looks a lot like a follicular lymphoma to me at low power, though you can see the nodules. But when you do the PD-1 stain here, the nodules are full of T cells, and there are very few B cells in those nodules. So the B cells, if you see them, are sort of pushed to one side of the follicle, and the T cells predominate. All right, so to finish off these nodal TFH lymphomas, they scare me to death, right? I look at them sometimes and don't even think they're lymphoma. And then we start doing the workup, and I'm surprised. So I'm always worried about them. Nodal TFH lymphomas can have Reed-Sternberg cells or Hodgkin-Reed-Sternberg cells, and they can be present. They can be positive for 15 and 30 and CD20. And I may have made the mistake at least once of calling something classic Hodgkin lymphoma in an older patient, and a year later they relapsed with obvious angioimmunoblastic T-cell lymphoma. So one of the things I tell our fellows is don't rush to call a case Hodgkin lymphoma in an older patient. Make sure it's not one of these things, all right? The patients with TFH lymphomas, it depends when you get them, right? And you know, in the old days with the angioimmunoblastic T-cell lymphoma, patients were usually sick. They had just a lot of disease and symptoms and laboratory abnormalities. You know, these nodal TFH lymphomas may be an earlier stage, and we're getting them earlier. You know, at least in our hospital, you know, when they really work these patients up early in the process, and they may not be very sick, and they may not have a lot of obvious laboratory abnormalities. The history of infection or immunodeficiency is helpful, right? I mean, AITL patients are famous for supposedly ampicillin treatment can cause AITL. It's not true, right? The ampicillin is given to a person that has cutaneous infections because of the immunodeficiency related to the AITL. So a history of infection immunodeficiency is a clue. And of course, flow cytometry is very helpful in these cases. And so it's become, in my opinion, mandatory. You can get very small aberrant populations, 10%, maybe less. 4 has to be positive, of course, and then you can assess CD10 and PD1 and a few of these by flow, and then of course you can also do them by flow, by immunochemistry if you have the tissue, right? All right, so that's you know, the world of nodal TFH lymphoma. I find it the most difficult aspect of diagnosing these cases. Let me move on now to a new entity, EBV positive nodal T cell and NK cell lymphoma. This is a tumor that involves lymph nodes, right? Primarily lymph nodes. It can have a T cell NK phenotype. It's EBV positive. They're cytotoxic, and it's usually adults, right? Now, if you remember in the old days, some of these were called the nodal version of nasal type NK T cell lymphoma, right? Now that's not true anymore. Dr. Ng in Singapore has done a nice job of working on these cases. Probably others too, but I know Sikbion has one of them who has shown that the gene expression profile of these nodal things is different from the nasal ones, and they should be treated differently. The clinical course of these nodal things is very aggressive. There aren't many papers on them. It's more common in Asia, of course. Here's two examples of EBV positive nodal T and NK cell lymphomas I have seen. The one on the left looks very high grade and large cell. The one on the right looks kind of pale cytoplasm, a little bit like nodal TFH to me. Here's the immunophenotype of a case. They're usually 8 positive. This is a T cell case, right? So it's 8 positive, 56 positive. You can see the markers for yourself, right? Ki67 high. Now, if they're NK, you wouldn't have the 8, right? 56 would still be there, of course. This is a little paper in the American Journal of Surgical Path from a group in China. Look at that survival for these patients. Holy moly. I mean, 20% are alive at 2 years. So it's a small group of patients, but the curve just makes the point. These are very aggressive tumors, right? So if it's in a node and it's EBV and it's T cell, think about this entity before you try to call it anything else, and make sure it's not one of these. Now, of course, the patients in this study and other studies don't have nasal involvement, right? People with nasal NK T cell lymphoma, oh, by the way, notice that when it's in the nose, it's NK or T cell lymphoma. When it's in the lymph node, it's T or NK cell lymphoma, right? A little switch there. But people who have NK T cell lymphoma of the nasal region can have regional lymphadenopathy in about 15 to 20% of the patients, and it can look a lot like this, right? All right, moving on now to the last category, because I'm already talking a little long, is PTCL NOS. So this is a heterogeneous category of nodal and extranodal T cell lymphomas that we cannot assign to any other category. And now we're excluding the nodal TFH cell lymphoma cases, and we're excluding the EBV nodal T and NK cell lymphomas. So the frequency, which I showed you in the beginning of this paper of 25%, might be going down now to 20% or something like that. There's a big spectrum to PTCL NOS. Let me just show you one. Here's two. One on the left is a small cell case. This is a little reactive germinal center to the far left compared to the tumor. The picture on the right is a large cell PTCL. Here's one with Hodgkin and Reed-Sternberg-like cells. These are really problematic. These Reed-Sternberg-Hodge cells can be positive for PAX5 and CD30 and less often CD15. And it's going to be tempting to want to call the thing classic Hodgkin lymphoma, but they're usually old patients. When they're old, think twice before you go there. You can still go there, but think twice before you go to Hodgkin lymphoma. Here's one that was CD8 positive in so-called Leonard-like pattern with these rows of epithelioid histiocytes, like corn rows, they call them. This is usually a lower grade version of PTCL NOS. Here's one so-called T-zone, right? I think these are very hard because you have a lot of, reactive germinal centers and the tumors, in between these germinal centers. And so I'm always worried about that one. Is it really lymphoma? I like to get help, by flow or by aberrant phenotype by IHC or by, flow cytometry. Molecular genetic testing for our clone, right? Here's another PTCL. This case is EBV positive. It's got necrosis. It's cytotoxic, right? This is different from the EBV positive nodal T and K cell lymphoma, right? It's a little different and rare, very rare, and prognosis is not good. All right, now how do you diagnose? Usually I'm showing you pictures there that's obviously lymphoma, right? Sometimes it's harder. An aberrant immunophenotype is common in these cases. Loss of antigens. I'm a big fan of loss. I'm not such a fan of dim versus bright. That I'm less comfortable with that kind of flow data. So loss is more my style. Very often, I think 7 is lost, and then 3 maybe, and then 2 and 7. Now, before we move on, I just want to, I think I've covered it pretty much. Flow cytometry, if not molecular, back up your PTCL diagnosis, right? Now, I just wanted to spend a couple more minutes on gene expression in PTCL. And this particular paper, which was written by Dr. Iqbal from the University of Nebraska, with the big team of the LLMPP group, right? Now, the idea with this paper was to get a large number of T-cell lymphomas together and then do gene expression profiling on them. And one of the first aspects of this paper, which I think you could predict before they even started, is that, the categories we recognize as AITL, ALCL, EN, NK, T-cell lymphoma, PTCL NOS, our characterization of them by morphology and phenotype and such had validity. And the gene expression profile shows that by showing signatures that kind of correlate with what these things have been classified as already by pathologists. Now, there are some differences here too. For example, here, they're showing that in the PTCL NOS group, 14% of them really had a profile more like AITL and 9% more like NK T-cell lymphoma, and 11% more like ALK-negative ALCL, and 9% more like gamma-delta T-cell lymphoma. So they're showing how gene expression profiling resulted in reclassification of some cases. Now, I would suggest to you this is exactly expected based on how I practice and maybe how you practice. And what I mean by that is you have a lymphoma, it's a lymphoma, right? And 90% of them are B. So you're looking at them and you're saying, okay, it's probably B, and it looks large, it looks small, whatever. And then, you get the markers back and it's T. You say, wow, it's a T case. That's interesting. So then you say, okay, is it PT cell NOS or is it something more specific? Is it AITL, for example? And then you look at the case and you say, well, it's got a few EOs, it's got a little bit of HEV, it's got a little bit of CD20 and 21 FTC proliferation. Well, maybe it could be AITL, but I'm not sure. So then what do I do when I think it could be, but I'm not sure? I call it PT cell NOS, and I put in the comment, the thing's got some features of AITL, but I'm not sure, right? And those are the cases that gene expression profiling is showing are AITL. That's what I would predict would happen based on how I do business, and maybe you do business the same way. When we say PT cell NOS is a disease of exclusion, in a way it's true, but it's different from B-cell lymphoma NOS, right? When you have a B-cell lymphoma case, you think about every possible B-cell lymphoma it is, and only when it doesn't fit anywhere else, you call it B-cell lymphoma NOS. With the T-cell case, at least in my example, I start with PT cell NOS. I start there, and then I try to make it something else, and if I can't make it something else, I leave it in NOS. And so it is a disease of exclusion, but at the same time, it's the preferred destination of a disease of exclusion, which is not the case with B cells. Now, one of the other big features of this paper, which was nice, is they showed that in the PT cell NOS group, there were two subgroups. There was a group that they called GATA3, that's in pink, and they do worse. And there's a group that they call TBX21, used to be known as TBET, and they are blue in the curve, and they do better. And so this is good, right? This is showing, trying to deal with the heterogeneity of the PT cell NOS category. And when you kind of look at this stuff in more detail, this is a very nice paper by Dr. Hevakan and team. I think Javid Iqbal is also senior author, or he's very much involved anyway. The TBX21 group, they usually have more inflammatory cells in the background, more upregulation of interferon and NF-kappa B, fewer copy number alterations. There's mutations of cytotoxic and DNA methylation genes. There's actually I believe they wrote a paper showing that DNMT3A mutations in this category may identify a distinct subset of the TBX21 group. They tend to do better. The GATA3 group, which is more involved in Th2 differentiation, fewer inflammatory cells, upregulation of the PTEN, PI3 kinase mTOR pathway, more complex genomic alterations, more mutations or losses of P16, TP53, other genes, more gains of MYC and STAT3, and overall a poor prognosis. Now, this is a more recent paper. Excuse me, I just lost track where I am. Okay, here I am. This is a more recent paper by that group trying to reproduce the molecular classification of PT cell NOS by using immunohistochemistry. And they're proposing this algorithm of 4 antibodies, and you can see the cutoffs. So you start with TBX. So this is a hierarchical system. This is a lot like the Hans system for diffuse large B, right? So you start with TBX21. If it's positive, it's a TBX21 case. If it's negative, use 20% cutoff. If it's negative, you do the CXCR3 one. If that's positive, it's still TBX21. If that's negative, you go to the GATA3. And if GATA3 is positive, it's a GATA3 case. If negative, you go to CCR4. If that's positive, it's also a GATA3 case. Now the cutoffs are 50% for GATA3 and CCR4. Now, is this going to change therapy? Probably not. Remember, the therapy for T-cell lymphoma is lousy. The clinicians admit that. But the idea is, can we use something like this to at least divide them into some groups and then maybe try some different kinds of targeted agents added into the standard CHOP type picture, panel, backbone, and see if we can just begin to claw our way into some sort of more rational approach to treating patients with peripheral T-cell lymphoma NOS. My last slide at the end of the hour is this little picture of Dr. Robert Collins. I just like to end with history slides. This is a slide showing that the first description of a T-cell lymphoma was 1973. And he was basically describing mediastinal lymphoma, T-cell lymphoma of the mediastinum, right? T lymphoblastic, I should say, right? That they used to be called Sternberg sarcoma. And so this is one of the reasons why the prognosis of patients with the whole field of T-cell lymphoma has been delayed because we didn't even know they existed till around the early 1960s, whereas we were dealing with B-cell lymphoma type things way back around 1900, right? So I just thought I'd end with this little picture. Dr. Collins, as you know, as some of you may know, was at Vanderbilt for most of his career and died maybe, I don't know, 10 years ago, give or take. He was in his late 80s. All right, well, that's all I've got for you today. So I can now, take a question or two, if that's what you'd like me to do.
Thank you so much, Dr. Medeiros. Thanks a lot. That was really wonderful. And I can see a few questions that I have shared with you in the chat box. Can you open the
Okay.
chat box on your side, Dr.
I see
Medeiros?
it. Let me give it a try. All right.
Yeah.
All right. So for question one is easy. In daily practice, we do not need to grade the AITL. Is that correct? Yes, that's correct. Right. I think the grade, I was trying not to use the term grade. I was using the word pattern because I think the pattern is good to know about to help us recognize them, but it's not at all needed to add to the diagnosis in any way. And I just think it's a tough diagnosis. So the more you know about the patterns, the better. A little bit like melanoma, right? I mean, there's 9 million patterns of melanoma, and they're all bad. If you know the patterns, you can't make the diagnosis, but at the same time, nobody cares about the patterns except us who have to make the diagnosis. Now, I'm looking here, the second one. Let me see if I know where we are. I was wondering what features can be helpful to distinguish between chronic active EBV from extranodal NKT lymphoma. That's a very tough one for me because I don't have a lot of experience with children and I don't have a lot of experience with chronic active EBV. At least in my own case, I don't think I can answer that question well. I'd have to ask you to ask that question to someone like Letitia Hitania in Germany, because she really has seen a lot of these cases and she knows what she's talking about. I don't know very well what I'm talking about with that. Sorry. Anything else before we?
Let me look at some other questions. So there was one question that was asking about peripheral T-cell lymphoma, NOS, versus Hodgkin lymphoma. If we have this RS-like cells in peripheral T-cell lymphoma, what is your experience?
Yeah, I have, I can do better with that one, I think. So, the standard teaching with Hodgkin lymphoma is that, you have big, bad, ugly cells, and then you have a background of benign cells, and there's nothing in the middle. There are no cells in the middle, right? So I used to, when I was in training, we used to say it was like the Grand Canyon in the United States. On the south rim, you had all the benign cells. On the north rim, you had all the ugly Reed-Sternberg cells, and there was nothing in the middle, just a hole, just a chasm, just a canyon, right? Now, PTCL, and for that matter, infectious mononucleosis shows you a spectrum, and so too does TCL. You usually see a spectrum of atypical cells in the background, smaller, larger, more atypical, and the large Reed-Sternberg cells, right? So that's one difference that I find very helpful. Difference number two is that I don't like to diagnose classic Hodgkin lymphoma in old people. I do it when everything is perfect, but when things aren't quite perfect, I always worry about these nodal TFH lymphoma type things or PTCL NOS. And then I think in that instance, it's really very helpful if you have flow cytometry or clonality studies, right? Now, my other experience is that in general, with the PTCL NOS, the big Reed-Sternberg-like cells, they may be 30 positive, but less often they're PAX5 positive. And less often they're 15 positive. Now, can a case occur of PTCL NOS with large Reed-Sternberg-like cells with PAX5, 15, and 30? Yes, but it's unusual. And so I think that would be helpful as well, the phenotype. 30 only is no reason to call something Hodgkin lymphoma in my mind if a person is older. Now, somebody's asking me, I was also wondering if it's okay to call it AITL instead of nodal TFH lymphoma angioimmunoblastic type. I think so. I mean, some of this stuff with terminology, what's the point? I mean, really. I mean, we went from Hodgkin disease to Hodgkin lymphoma. Okay, I made the switch like everybody else did. I don't want to be accused of being stupid, but was it really needed? I don't think so. At the time, now I've been doing it 20 years, so I'm used to it. Maybe in 20 years, we'll be used to the nodal TFH lymphoma angioimmunoblastic type. But I think most people still feel pretty comfortable with AITL as an abbreviation and angioimmunoblastic T-cell lymphoma as a name. So I still use it. I call these tumors angioimmunoblastic T-cell lymphoma, and I put in the comment, the new WHO-5 suggests we call them nodal TFH angioimmunoblastic type. That way people won't say to me, well, Dr. Medeiros, you don't know what you're talking about. You're out of date. Now, the next question is, mediastinal T-cell lymphoma, is it still an entity? Well, I was talking about T lymphoblastic lymphoma. And yes, I believe that's still an entity. Do you consider prominent FTC proliferation around HEV somewhat specific for AITL? I do. I'm not saying it can't happen in other things, but I think the FTC proliferation is pretty characteristic of AITL and unusual in other kinds of T-cell lymphoma. Dr. John Casey Chan from Hong Kong wrote a paper years ago in I want to say the journal is Histopathology, where he looks at CD21 and maybe 30, 40 cases of T-cell lymphoma of different types, and the only type that had a lot of them was AITL. So I do. Now, the problem with the FTC proliferation is it's wonderful when you have it, and it supports, nodal TFH angioimmunoblastic type, but it's not there in some of these nodal TFH lymphomas. It's too soon, I suppose, in the pathogenesis for that to happen. And so you don't see that. And that's one reason why I struggle with these nodal TFH lymphomas a lot. Now, the next question here is, could you briefly comment on PT cell NOS with TFH phenotype versus nodal TFH lymphomas? So I think I understand your question. So, I mean, to me, I tried to give a little history just to sort of fit it in, right? I mean, TFH, so PTCL NOS with a TFH immunophenotype would be the WHO4R terminology, right? And nodal TFH lymphoma NOS would be the WHO5 terminology. And to me, they're the same. It's just that the name has changed. Another one of these terminology things, right? And to me, a nodal TFH lymphoma with a TFH immunophenotype basically doesn't look like AITL, or it has a few features suggestive of AITL, but not enough to feel good that it's AITL. Certainly not the FTC proliferation, but has the phenotype. And the literature suggests that those tumors do just about as badly as the typical AITL cases. And the mutation profile is similar, but the IDH2 mutations seem to be confined to the angioimmunoblastic type.
Thank you, Dr. Medeiros. I think these were the questions that I found on Facebook and YouTube. I don't see any more questions. So now before we conclude, let me just quickly share my screen. I can show you that this is, thank you all. Thanks to our viewers for joining today. And Dr. Medeiros, you would be happy to know that we had so many viewers who joined from many countries, including Ethiopia, Sudan, Mexico, Bolivia, Ghana, Bangladesh, Saudi Arabia, Tunisia, Brazil, and special shout out to a lot of trainee residents who joined from Jorhat Medical College in Assam, India. Thanks for your enthusiasm. It is always good to see trainees interested and joining for these lectures. And for our viewers, please don't forget to follow our channel on different social media platforms, including Facebook. Don't forget to subscribe to our YouTube channel, then on Instagram. And you can also scan this QR code so that you can get access to our Instagram account. We are also on X. so that you can follow us and stay tuned to all our upcoming lectures and also the archive lectures. And our next lecture is the next hematopathology lecture series. So that would be on cutaneous B-cell lymphoma. And we will have Dr. David Casarino. He will be back. And last time he was talking on cutaneous T-cell lymphomas. So, and on July 9th, he will cover cutaneous B-cell lymphomas. Hope to see you at that time again. And thank you so much, Dr. Medeiros, once again for joining us. Thanks a lot.
My pleasure.
We really
Thank you. And thanks to my friends out there across the world. It's exciting to hear they're listening from everywhere. Thank you.
Thank you. Thank you.